Hi, I'm Dr. Christopher Bunick, Associate Professor of Dermatology at Yale School of Medicine, and your Editor-in-Chief of Dermatology Times. In the first session, several posters were highlighted, and one in particular stood out to me because it really signified the knowledge gap that emergency room physicians have in regard to treating atopic dermatitis. This particular poster did an analysis through the EPIC charting system and asked a simple question. What were the treatments that emergency room physicians were using to treat atopic dermatitis flares among pediatric atopic dermatitis patients coming into the emergency room? Most of the prescribed therapies were weak topical corticosteroids, or oral corticosteroids, or oral antihistamines. These types of therapies, weaker corticosteroids, avoidance of the advanced nonsteroidal topicals, that's sort of backwards to what we're learning from our consensus guidelines, whether it's the American Academy of Dermatology or other types of consensus guidelines put together by experts. We're trying to reduce topical corticosteroid use, certainly prolonged corticosteroid use, and promote advanced nonsteroidal topicals. Similarly, when it comes to oral therapy of severe psoriasis flares, whether it's pediatrics or adults, we're really trying to move away from using oral corticosteroids. They're the least safe option. They're also highly ineffective with high rates of relapse. We really don't want oral corticosteroids being used as a first-line oral option for long periods of time. Anything greater than 30 days has been defined as long-term use of oral corticosteroids for AD. And in this particular poster, in addition to using oral corticosteroids, approximately around 20% of the ED patients that came in were receiving this. But what was also being used for atopic dermatitis were high rates of antihistamines, which we know in atopic dermatitis does very little to help the skin, and it actually does very little to help the itch. What can we take away from this particular poster? It's that there's still a huge knowledge gap between what we are doing in dermatology to advance the standard of care of atopic dermatitis patients from both a topical and an oral approach, and also an approach to managing acute flares. That knowledge that we are accumulating and learning in dermatology, it has not trickled down into urgent cares and ER and the emergency rooms. We need to help make sure we spread the word to our colleagues that are managing urgent care centers and emergency rooms that there are certain guidelines and protocols that could be done to manage atopic dermatitis a little bit better than just using weak topical corticosteroids, oral corticosteroids, or oral antihistamines.